Next speaker is Suha. Suha Alkhraisat is an experienced nursing professional with over 27 years in healthcare field. Throughout her career, she has demonstrated a strong commitment to patient care, clinical excellence, and continuous professional development. For the past 10 years, she has specialized as an adult stem cell transplant and cellular therapy nurse coordinator, where she has played a key role in managing complex patient cases. Her career reflects detection, leadership, and passion for improving patient care in the specialized field of stem cell transplantation and cellular therapy. Ms. Suha, mic is yours.
Thank you so much, Mariam, and good afternoon, everyone. Now we will start with the live presentation. Thanks, first of all, Happy Nurses Day for all of you. Even this is our week, so we should be proud, all of us, of taking care of the patient, especially with advanced treatment. And my presentation will be so simple regarding what is about leukemia and multiple myeloma. So I hope you will get at some information, especially the latest update for the treatment of leukemia, and also when we take these patients for transplant. Okay. Yeah, okay, back. This is actually my learning object. We will define the disease framework. We will talk about mechanism of transplant, evidence-based selection of the patient, and the clinical surveillance of the patient. So what is the leukemia? We usually, all of us, we working with hematology patients. Most of our patients, they have leukemia, lymphoma, right? What is the leukemia? The leukemia actually, it's a cancer in a blood form tissue. This is the most important to know. And it's primarily usually in the bone marrow, causing overproduction of abnormal cells, white blood cell. This we call it, the abnormal cells, we call it a blast cell. So it is they usually diagnose percentage, how much percentage of these blast cell in the bone marrow. Usually the first signs of the patient, he will have fatigue, he will have infection, easily bleeding. Because that, sometimes patient will come, when he come for the complaining of fatigue more than 2 months, 3 months, or sometimes easily when he bleeds, it's hard to stop the bleeding, and fever, all of these. So it's categorized, the leukemia, it's depend on the fast it's grow. There is kind, we call it acute, and there is kind, we call it a chronic, and all the type of cell affected. So the acute, what is the acute? It is AML and ALL. AML and ALL, it is fast growing, which is aggressive, and it's required immediate treatment. The moment you transplant the patient AML, even the patient midnight, weekend, they do excellent fast to assist the patient to start the treatment directly. They don't wait for the acute stage, which is AML or ALL. AML is effect in myeloid cell, ALL, it's effect in lymphoid cell. Usually AML, you will find it with the adults, rarely to find pediatric has AML. But ALL, most patients actually with a pediatric, and also some elderly patients, they will come with ALL. For the chronic phase, which is slow growing, we call it CML or CLL. Why slow? They are still function, but function poorly. They don't produce, they don't act as a right way, as what is the body need, which is commonly CLL and CML in the adult patient. You will never see pediatric is diagnosed as CML or CLL. There is another part, we call it about bone marrow failure, which is MDS. All of us, we heard about the MDS. MDS, it's malformed in the cells. The cells, the number of cells is right number, but the way the function is malfunction, which is often, we call it pre-leukemia, which because usually most of the MDS, if they're not treated or not controlled, they will be transformed to AML. There is a quick comparison table about, we have AML. AML, what's type of the cell? Myeloid cell. Primary audience, usually adult. Key, fast growing, area rod often present. ALL, lymphoid, malian children, most common childhood cancer, it's aggressive. CML, as we said, myeloid, middle age of the adult. Philadelphia chromosomes, there's 3 phases of the CML. CLL, lymphoid, early adults, adolescent actually slow, often found by chance. Usually, you will never diagnose CLL just only by chance all the time. MDS, it's mixed, myeloid and elderly adults, as we said, ineffective blood cell productive, and they will come with low count. The diagnosis, usually how we diagnose, all of you know, usually CBC, blood smear, bone marrow biopsy, and cytogenetic. AML. This is the type of the treatment of the AML. We have 3 categories. They classified the AML 3 categories. They call it favorable risk, which is when he has, you will see sometimes the doctor, they wrote AML, favorable risk. He has NMB1 mute with or without flat 3 ITD, CEBA, and also invergent 16. Intermittent risk and advanced or adverse risk. There is no high risk, they call it adverse risk, which is complex karyotype, TB53, ASX1, RUNX1. So these type, when they classify these patients, when we refer them for transplant, for favorable risk, it is not totally deferrable. It's not really need to go for the transplant if he is in CR, okay? Or he is sometimes, unfortunately, sometimes the patient, they will relapse, they will refractory for the disease. That the time we will take them to the transplant or relapse. For the intermediate, HSCT actually is kind of recommended, highly driven by MRD status, usually if MRD positive or negative. Sometimes you will find patient morphology in remission, MRD positive. This will tell me I should take this patient for transplant. The other things about this patient also, the availability of the donor. If he has a full match donor, I will take him for transplant. But if he doesn't have, sometimes we do not take him for Hablo or for MUD. Since he does have match donor, we will take him. But also still, it depends how he responds after he received the induction. The adverse risk, this is strongly recommended for allostem cell. The moment he will have NCR, you should take this patient directly for transplant. ALL actually the most powerful trigger for this, MRD. The predictor for ALL, MRD, if the MRD positive or negative. As we're saying in B cell and T cell, it should be the MRD. If the patient CR and strictly indicated of high feature, Philadelphia positive or Philadelphia-like, MML, hypodeblipidemia or resistant MRD more than 0.01, that the time after he received the induction and consolidation, because it depends, sometimes we're using different, sometimes after induction will be positive, but after consolidation he will be negative. This patient, we do not take them for transplant, especially the B-cell ALL. If they, after the consolidation, he is positive, that the time I will take him to a transplant. In 2026 now, there is a bridging. This is the EBMT highlighted using blinatumomab any patient has positive MRD with ALL, you should give them blinatumomab as immunotherapy as bridging to clear this patient prior he reach the transplant, okay? And actually it's showing much significant improvement in the survival rate. So then we will come to the CML or the CLL. Actually, the core treatment for them, there is a lot of target therapy for the CML. It's reduced the requirement for the transplant. So it is really, will be the last choice for them to take them for the transplant. When I will take the patient who is diagnosed as CML for transplant, first of all, TKI inhibitor failure. TKI and failure, it doesn't mean one TKI. There should receive 2 minimum TKI. If he failed these 2 TKI or he could not tolerate this TKI because some patients, they cannot tolerate this medication, or he progression in top of his taking the TKI. So these patients at the time, I will take them for the transplant. Or he has the T31F1 mutation, which is ponatinib resistant. You will see patient ponatinib resistant. This time, I will take him to the transplant. Or sometimes he is CML, but he comes with accelerated phases, or he has a plastic crisis, okay? This time, I will take them for transplant. For the CLL, extremely rare to take the patient actually for transplant, restricted for also, they will be refractory to BTK inhibitors and venetoclax, TB53 abbreviations, and with progression or Richter transformation. With the Richter transformation, because sometimes you will have patient Richter transformation, before they used to give choices for the auto. Now auto is strictly not recommended for any Richter transformation. As you know about transplant, we have auto stem cell and we have allo stem cell transplant. Auto, we are own patient cells, and the mechanism we are treating the patient, we will collect the dose what we need, and also, but the good thing for auto, he doesn't have any versus GVHD or something, but he has high risk for disease relapse, right? But the allogeneic, it need a donor, HLA matching donor. It is mechanism immunotherapy, relieve the graft versus the tumor, and we have GVL. You will heard always they will saying there is a GVL. GVL, it's the effect of the GVL because it is clear the residual disease. Because you heard sometimes it's better the patient let him have GVHD because then I want to increase the GVL. GVL, it can control the disease. Okay, so it is, as we know, all of us we know, unfortunately, allogenic has always there is a risk for GVHD. Okay, but most of the time, if thanks God, with all these new treatments, a lot every day we have a new treatment, it is curative. Eligibility. Before, as you know, we used to put a cut-off age, right? But now there is no age. Limited for transplant, no age. The most important, they focusing in the heavily of performance status. If between 0 to 2, preferable, and the comorbidity score. Sometimes young age, but the comorbidity score high. So I will defer him from the transplant, right? So let's say he came 70 years old, he is fit, his comorbidity index low or 0, so I will take him for transplant, okay? Organ benchmark, also the strict organ function baseline must be met prior the clearance. Usually the GFR, they said more than 30, and the LVEF is more, left ventricle function is more than 45%, and also social support is confident as a critical factor for both transplant and safety and sure decision making. As you know, we are living in Riyadh. Actually 50% of our patients out of Riyadh. If they don't have a family support and social support to stay in Riyadh, it will make a major effect, a major role in the decision of take this patient in the transplant. And we sometimes decline or defer this patient because he doesn't have any social support or family support. Now, this is about leukemia. We will move to multiple myeloma, and it is multiple myeloma. It's really a huge number of our patients. Now we have multiple myeloma diagnosis. So multiple myeloma, I will talk about just overview and the risk. How they criteria to diagnose the multiple myeloma. As you know, there is International Myeloma Workup Group. They put criteria for the diagnosis. They requires clonal bone marrow plasma cell. The clonal plasma cell should be more than 10%, or biopsy proved there is a plasma cytoma plus one of the following. There is a CRAB criteria and there is a SLIM criteria, biomarkers. A CRAB criteria, the calcium more than 11, the renal creatinine less than 2 milligram per daily, or creatinine clearance, it's less than 40. Anemia, hemoglobin less than 10, and all 2 below normal. Bone lesions should have one or more than one bone marrow lesion. The SLIM biomarkers, 60% clone plasma cell cytoma, light chain ratio more than 100, MRI more than one focal lesion. And also, depend on what is the you diagnose what the patient has, they staging, stage 1, stage 2, and stage 3. It depends. And also they put overall survival depend on the diagnosis staging. If the patient is stage 1, they consider around 80 to 82%, the patient can 5 years alive, overall survival. Stage 2, it's a drop to 62%, and stage 3, it's between 40 to 40%, the 5 years survival. As you know, myeloma, it's not a curative disease. Just only we are prolong the safety to not progression disease, okay? High risk category, which is deletion 17p, this is the things you will find it in the bone marrow and the cytogenetic for you. And also sometimes you will hear double hit or triple hit, which is more than 2 high risk abnormality. There's actually donated a very poor progression. Multiple myeloma, this is the standard gold of the treatment. As you see, the front line for a transplant eligible patient now, if you see, it is quadruplet, which is DARA RVD. Before DARA, we use it when the patient is refractory or the patient failed or progression or these things. Now they frontline treatment because it is reached 95% CR rate. So the quadruplet treatment, DARA RVD. Before some doctors, because also DARA availability and disease, some people, they still keep the DARA second line treatment. So they give a triplet RVD, which is that before that what they use, which is decreased the CR rate to 78%. The old it was VD, so it's 45% the CR rate. So, and the autologous stem cell transplant is still a standard treatment for the multiple myeloma. He will finish the treatment, he will go for the transplant. As we said, also, myeloma, you can take patients 70, 75 years if he is fit and his comorbidity index it's low, all of these, still we can take the patient for a transplant. The core inside, you need to understand, as I told you, the stem cell, it's not curative. It will not remove the plasma cell, but it will delay the progression rate, survival rate. It will be delayed. So can be survival 2 years, 3 years, 4 years, it depends. Before they usually saying, because they used to use the old VD, they said it's 10, 12 to 18 weeks, to 18 months post-transplant, they will be sure the patient will come as a relapse. But now it's coming after, it's becoming more. It's reached 5 years. طبعا before also, if the patient relapse after after auto, we used to take them for allo. But now there's a lot of new novel agent, a lot of treatment, and there is availability of the CAR-T. It's make allo, it is not really preferable. And actually what they transplant, all the myelomas, they found it is no benefit, no different in survival rate. It's still the same. So as we see, myeloma, usually we give them induction, 4 to 6 cycles. After 4 cycles, after 3rd cycle, they do assessment if the patient doing well. Then they will take the patient for stem cell collection. They collect the patient, cryopreserve. Usually, we're targeting 4 and above, because this is, as you know, still until now, most of the myelomas physicians, they still believe they will ask you to collect for 2 transplant. As you know, tandem is 2 transplant, but even it is less, but it still will be do. Then auto stem cell transplant yield deeper, rapid response, and as I said, longer progression-free survival rate. Delayed transplant, actually, it still can be, but it will less the survival rate. Then the maintenance, all the transplant, post-myeloma, post-auto transplant, they need to be kept on maintenance, which is usually do lenalidomide. We will continue until the patient has progression or intolerance. This is about the, usually بالمyeloma, you don't need to reach the CR for prior transplant. Sometimes BR, sometimes they go VGBR, CR, and also sometimes minimum residual disease. I will be fast because my time is out. You see, now before they saying transplant, as now, thanks God, we have CAR-T. If the patient from the 1st to 3rd line, prior lines, he's relapsed, all the committee, they are suggesting to go direct to CAR-T. 70% they recommended to go for CAR-T, not even auto. If you see cell-to-cell, it's available now, and we can take the patient for the CAR-T. 15% is still they saying to go for auto, and 15% they are saying to biospecific or clinical trial. Okay, as we said, is allogenic, it's limited rule, and it doesn't change the benefit, and the mortality rate is higher. This is also, we already saying about tandem consolidation and maintenance. And the long term, usually day 30, we wait the patient for engraftment. Day 100, we stay the protocol. We start maintenance. For the myeloma, we give lenalidomide. For the AML, if he is FLAT3 positive, we will start IDH, and also the vaccination, and we send the patient after 2 years, we start searching for secondary malignancy and all over, maybe hypothyroidism, endocrine, and these things, dysfunction, the other organism. For your nurses, you should CAR-T, you should be worried about the CRS and ICANS, GVHD monitor, and the cytopenia care. As we said, this is a universal principle. We should have multidisciplinary consultation is essential to decide this patient go to CAR-T, go for transplant, or he is not fit for transplant. Okay, as we said, this is the indication, as I mentioned earlier for you. And this is just as a discussion, like a geriatric assessment myeloma. How do you approach the transplant conversion with 72 years old, newly diagnosed multiple myeloma, demonstrated a good function status? As we said, years age is not a matter, so he has a good performance, so I will take him for transplant. The risk-wise benefit in AML for patients presented with intermediate risk AML in CR, fully matched sibling donor, what specific factors influence your recommendation for or against allostem cell transplant? As I said, I have a fully matched donor. Why not to take him for transplant? If I don't have, no need to take him for transplant, the intermediate risk, okay? The cellular therapy distribution, it is an emerging availability also. There is a CAR-T therapy, there is biospecific antibodies, all of these alternatives to not reach to use the transplant. This is my reference, and thank you so much.
Thank you so much for the nice talk. Any question? Okay, I have one question for you. How do you see cellular therapy changing future in hematology? Future in hematology.
Actually, stem cell, it will be... okay. Actually, it seems stem cell, it will be less requirement with all of, as I said, we have CAR-T, we have gene therapy, genetic also now. So the auto, it's more or less. The allo still, actually, it's still required, but also all of these coming environment. You don't know, every day we are seeing the biospecific sometimes of novel agent, they helping the patient instead, because as you know, stem cell, it's a lot of complication, and the long-term survival with all the secondary malignancy, all the dysfunction, it still has really, it's not a good. Usually, I'm usually saying about the allo stem cell, free disease but miserable life, because long term, they will patient will, its whole life he need to coming these things. Okay. Anything else? Any question? Yes.
Suha, thank you so much for that presentation. Two questions: AML and myeloma. For AML or leukemias, going for transplant, you have mentioned that it will be tackled in the multidisciplinary meeting.
Yes.
How strict is the compliance of your patient in here? For example, only like if they don't take their medication, we know the allogenic is a long process, it's a long journey. Do you really defer them for transplant if they show that they are not compliant with their medication?
Yes, actually the moment because we have a weekly discussion, all the patient, the coordinator who is responsible to this patient, he will say this patient actually is not coming, not compliant with his medication, not compliant with his appointment. You need the patient to have a long survival, these things. If he's not compliant, 1 or 2, 3, talking to them. The doctor, the consultant, his MRD, they will talk to them. The coordinator, they will talk to them. Stem cell consultant, he will talk to him. If he's still the same behavior, yes, we defer the patient.
Okay, so I'm impressed if the doctor listened to the nurse saying that this patient is not compliant.
Yes, we
They
are
take your
saying and we document. You know, it's a big decision to defer, as the patient sometimes he require transplant. You show, and also we document that in the patient file. Okay,
all right. We will learn from that experience, Suha. Second one, on the multiple myeloma. So you mentioned about cilta-cel, the CAR-T for the multiple myeloma, rather than like for a plasma cell leukemia. Okay, so plasma cell leukemia, let's say you have a young adult female patient, let's say around 40, good performance status, have a good response, BGPR to almost CR after 4 cycles of DARA VRD. Do you, what does your organization does? Do you go to cilta-cel or you go to auto?
First of all, cilta-cel, he should have a disease.
Okay, so
multiple myeloma for auto, if he has BR or VGPR, I will take him for transplant. Okay. For the CAR-T, we put it for refractory or persistent disease.
All right. What about oligosecretory?
What is it?
Oligosecretory multiple myeloma.
Yes.
The patient have a stable disease, but there is a disease. Okay?
Yes.
Now, oligosecretory doesn't come out of the biochemical markers, kappa lambda, no M-band, but in CT scan, and sometimes even in the bone marrow, hit that part of the marrow that there is the patch of the plasma cells, then you can say that there's an increase. Now, you're saying currently because it's very
I will
costly.
give you an example. We have a patient actually, biomarker improving significantly. Bone marrow, there's no plasma cell, but MRI is still showing he has lesions,
Yes.
multi-lesions. So we'll take him for CAR-T.
Okay.
Okay, so it is depend. Stable disease,
Yeah.
that means he's not responding, but he's not reprogression.
Sahih.
So the decision will be, as I told you, multidisciplinary. We have CAR-T committee, all the physician with the myeloma's physician. They will discuss what is the good, what is the benefit for the patient. The moment they will decide, well, which is actually CAR-T, cell-to-cell, it's a tremendous survival rate. Yeah, more than 95% for cell-to-cell. So I will give this patient for a chance, as he's young, as you're saying, young. Why not to take him for the CAR-T? And this is what actually doing. We take them for CAR-T.
Okay. So I guess we will refer to patients then here.
Welcome.
Thank you.
Yes, Mr. Bashir. There is a mic for Bashir. Sorry for the next. I take your break time.
Okay. Thank you very much for your presentation.
Yeah, welcome.
As you know, BMT, the main purpose is for curative. So
Yes.
as I mentioned, for lymphoma and leukemia, we achieve complete remission. But what is the reason behind that the myeloma is not achieving complete remission? If they are not achieving complete remission, what is the extent of involving them in these difficult procedures, cytopenia, and later on, just a quality of life? Or else, why can't they not go direct for the stem CAR-T cell?
What is the last thing?
I said, if at all they cannot achieve complete remission,
Complete remission, I cannot take. Cell to cell, the cell is fighting the leukemia plasma cell. You know, there is no plasma cell, nothing for him. So why I should give him CAR-T? CAR-T concept of the CAR-T in ALL, in AML, in ALL, in lymphoma, myeloma, it's fight, they generate the cells to kill the disease cells. Not to just to give it and that's it. No, because this is the concept of the CAR-T. CAR-T, they make it smart, they generate it smart to kill the tumor cells. This is the concept of the CAR-T. How I will take the patient, he doesn't have disease. What is the CAR-T will do in this patient? Nothing. But why we said in myeloma, no need to reach CR prior transplant. But it doesn't mean I will take him with the full disease. Small burden of the disease. Small burden. If more than 75% of his disease is gone, that I consider him, he's really partial. More than 90% VGPR, I will take him. This is why my category. And this is before CAR-T. Now we are really, even if he has, we look to the case, the whole case. Now, if he is age young and he is 50%, let's say he responds, no, I will take him for the CAR-T if he has any benefit of the CAR-T. You get it? Actually, cell-to-cell, maybe CAR-T, it will be replaced, the transplant, if the patient, even if he has low burden of the disease. Okay? Because now it's considered after the first line of the treatment, you can take the patient for the CAR-T, because before it was considered after 3 lines of the treatment. But actually, I should not talk about the CAR-T. I have my other colleagues, they will talk about CAR-T therapy. Okay, thank you so much, appreciate it.
Well, we'll have 5 minutes break.